So, welcome to Mastering Burns Management, a paradigm shift of treatment strategies. We're delighted that you can join us from the global audience tonight. We've got two of the leading global experts in burns joining us. We've got Dr. Paul Glatt, who's based in Pennsylvania. Welcome, Dr. Glatt. You're the director of the Burns Unit. And you live in an unpronounceable town, I'm afraid. I'll need your help with it. It's almost like a Welsh sounding.
It is a Welsh word, but let's just say Philadelphia. It's a pleasure to be with you
That
guys.
makes life easier. And then we've got Prof. Kimball, who's joining us from Brisbane. And Prof. Kimball is the clinical director at the Centre for Children's Health Research at Queensland Children's Hospital, based in Brisbane. So we're really delighted to have two of these leading world experts on burns joining us for this session. So welcome both.
It's a pleasure. Thank you.
Thanks very much.
Thank you.
Thank you. And Prof. Kimball, we'll come to you first to give us your insight of decades of experience of burns. You're going to distill all of this for us into some really key messages for our global audience on how to manage particularly pediatric burns.
Yes, thank you very much. I'm a pediatric surgeon, so really I can only talk about children. But a lot of the principles I'll be talking about certainly apply to adults. So I'm speaking from Brisbane. We treat kids with burns up to the age of 16 for new burns and 18 for follow-up. And what I'm going to go through is a lot of the principles, and I'll take you back. I started here in Brisbane last century, in fact, in 1999, and things were not good then. We didn't have good pain control for kids with burns. The agents we were using were very cytotoxic. The dressings we were using were cytotoxic. We used to put silver-sulfadiazine with chlorhexidine, slobber this on kids, scrape it off every day in a bath. And we know this is very toxic. As I say, we were doing daily dressing changes. We had very limited access to general anesthetics and theatre. And we saw this inevitable wound progression, which Jackson described a long time ago, and we'll talk about that later. So things were not good, and the outcomes as a result were very poor. Fast forward to this year, and things are totally different. We've got prevention going very well. So we're seeing a lot of the mechanisms we were seeing in 1999 just don't exist anymore. First aid, we think, is so important. That's got huge uptake here in Australia. Pain control, we've got algorithms for that, and we consider anything above a 2 points and a 10-point scale an adverse event here. So kids should not be in pain having burns dressings or any time during the burns journey. The cleaning agents are non-cytotoxic. We'll talk about that. And the dressings we're using are much lower in cytotoxicity. We don't change dressings every day now. At most, we'll change them twice a week, but most of our dressings are full week. We've got excellent access to theatre. We use a lot of negative pressure wound therapy. And what we emphasize here is the importance of the first 24 hours in that patient's burns journey. Just going back to the basics with the skin, you get a burn. It's actually very rare in this country to have a full thickness burn. So it's partial thickness, and we're relying on reepithelialization from these skin appendages. And the faster you can do that, the better. In the old days, we used to see a lot of full thickness burns, but that was because the burn deepened over the first 72 hours or so. And I go back to the Jackson model I talked about before. So back in the 1950s, Douglas Jackson in Birmingham in the UK described what you see in burns. And that's when you see it initially, you think this is a partial thickness burn. And over the first 3 days, that burn appears to deepen. And he described the 3 zones of a burn, the most important being the zone of stasis, which is just outside the zone of coagulation and inside the zone of hyperemia. And it's all about this zone of stasis. Douglas Jackson didn't think you could actually do anything to save that. He just was describing the progression of a burn wound. In other words, the zone of stasis died off, and that's why you were seeing the deepening of the burn. But nowadays, we know that you can save that zone of stasis with all the things I'm going to be talking about, starting off with first aid, analgesia, fluid resuscitation, etc., etc. So that's not an inevitability, like Jackson said. We know we can save it, and we've known we can save it for, in fact, since last century. And that's the principle of our philosophy in burns is all about saving the zone of stasis. Now, this is actually not a new concept. If you go back to the Egyptian papyruses, this is now 3,500 years ago. There's a beautiful translation by Sir O'Brien on the Ebers papyrus. And it goes like this, and it says, another remedy to drive away the turning white of a burn. And then it goes on to how you actually do it, which I wouldn't recommend today. But this turning white of a burn is exactly what we see if you don't treat a burn properly, it deepens. And so they knew this 3,500 years ago, and it's taken that long for us to start doing this. We know that there's a relationship between the time a burn takes to reepithelialize and the incidence of scarring. And you see this beautiful sigmoid curve, which was created by this is, I call the chip paper from Birmingham in the UK. It's a beautiful graph. And that's the up part of that sigmoid curve is around 17 days. And we actually use 17 days as our cutoff between needing scar management and not, simply because burns which reepithelialize before 17 days are very unlikely to form a scar. We've actually done our own sigmoid curve looking at almost 800 patients in our unit here, and it's remarkably similar to the chip paper. So this is a real thing, the 17-day for that upturning of the sigmoid curve. And of course, scarring is a problem. It's what everyone wants to avoid in burns. And although we've got fantastic treatments now to try and make scarring as less as possible, you still don't want to have it if it's at all possible to avoid. So for scarring nowadays, we've got silicone ointments, we've got pressure garments, which we're using a lot less now than we used to. But we've got all the other things. We've got microneedling, CO2 fractional laser, pulse dye laser to get rid of redness. And now the new boy in the block is vacuum roller massage, which is proving to be really, really good. The huge benefit of this is, of course, you can do it awake. So lots and lots of scar modulation treatments at her fingertips, but you don't want to get this far. So let's go back to the problems with scarring. We've designed here a scar tool, which actually doesn't just measure the scar itself. It also looks at the psychosocial effects that scar has on the child and family. And we've been using this for several years, and it's translated into many languages and used around the world. But what it shows is that huge impact on the child and the family from having a scar. So we really want to avoid that. We also know that there's a really strong relationship between the burn wound and its reepithelialization and the patient's pain, anxiety, and stress. And we've shown that if you can reduce any of these, then you increase the rate of reepithelialization. So it's so important to get these stress levels down and pain control. Can't emphasize that more. We also know now exactly who gets more pain in the pediatric world. And it's no surprise that it's the kids with the feet and hands burns. 50% of all the kids we treat have got feet and hand burns. Very, very common, and most of them are toddlers. We know that it's the burns where there's multiple sites involved. Deeper burns cause more pain, and of course, larger total body surface area of the burn. We've also noticed if that child has the first dressing outside our hospital, the pain scores are higher later on. And that's probably because in a lot of places, the treatment has been suboptimal. The child's had a bad experience, and that will escalate the pain scores later on. So we know exactly who gets more pain, and we can actually have an escalated pain pathway for these kids. So you don't have to wait until a child has pain. You can predict it and give them proper analgesia before the dressing change. And if you're predicting that your oral medication is not going to work, we give these kids general anesthetic. We've got 2 lists a week where all we do is dressing changes under general anesthetic within our burns unit. So I would say in this day and age, it's unacceptable for a child to have pain during dressing changes. Now, going right back to the basics, how do you prevent that zone of stasis from dying off and deepening the burn? Well, it starts right at the very beginning. We know that first aid is very important, and we know now what the optimal first aid is. And so we know it's 20 minutes of cool running water. Anything between 2 and 15 degrees centigrade is absolutely fine. And if you can't get to it straight away, a delay of up to 3 hours still is worthwhile. And of course, these recommendations work for most of the world. Now in Queensland, where we're subtropical, the temperature of the water coming out of the taps is 15 degrees. But where I came from originally in Scotland, the temperature in most winter months is nearer that 2 degrees. So these recommendations work worldwide. And we know that ice doesn't help a burn. In fact, it will increase the chances of hypothermia. And all the alternative treatments which you hear for burns, such as hydrogels, and all granny's remedies, none of them actually will lessen the depth of that burn. And so they should only be used as adjuncts to proper first aid, which is 20 minutes of cold running water. And we've shown this not just in our animal model, we've also shown it in our large cohorts of kids. This is a paper from a couple of years ago, where we looked at 2,500 kids with burns and saw the effect of either having first aid or not having first aid. And what we showed is that without first aid, the chances of having a full thickness part to your burn increases. And you can see that the different increments of first aid, as you go up, the chances of having a full thickness depth burn go down. The chances of requiring hospital admission, again, is directly related to the amount of first aid that they had. Whether they need to go to theatre is again related to first aid. And the chances of having skin grafting as a result also decrease the more first aid you have. So it's very, very important. We also know that the delay in getting to a tertiary burn centre, for every day delay, the chances of revitalization early decreases. And we can measure that. And this is for our own patients in Brisbane, but I'm sure it applies around the world. So the importance of getting any significant burn to your burns unit as fast as possible is really, really important. Cleaning burns, very important to decrease that colonization risk. And we used to use a lot of chlorhexidine. And chlorhexidine is a great substance to kill bugs. Unfortunately, it also kills keratinocytes. And so we don't use this anymore. What we do is we actually use a substance called QV, which is, it's not quite a detergent, but it has a detergent-like effect, but it's totally non-cytotoxic and is a great cleaning agent for that burn and for subsequent dressing changes. We tend to give a rinse of 0.2% chlorhexidine right at the very end. And we started that during the COVID time, and we've actually carried on doing that, but it's just a quick rinse rather than a scrub with chlorhexidine. Now, what we really promote here in Brisbane is that first burns debridement that really has to be as good as possible. Now, I'm not talking about surgical debridement. I'm talking about just giving that wound a really, really good scrub down with gauze, just getting rid of blisters, debris, and getting that burn ready for that initial dressing. Now, to get that good scrub, you've got to give decent analgesia. And if that can't be done with the patient awake, we put them to sleep. So we take a lot of kids to theatre in that first few hours after the burn, just for that initial scrub. Remember, this is not a surgical scrub. And what we've shown is that you can speed up the rate of rehabilitation just with that initial scrub. In fact, it's a whole 5 days earlier as a median that you're getting rehabilitation. 15 days compared to 20 days. And you see that that is quite significant because it actually straddles that 17-day mark where we have the cutoff between scarring and not scarring. So we see this as very, very important. And really to convince our theatre staff, our anaesthetists, we published this a few years ago, and you can't argue with the evidence. The dressings which we eventually apply to the burn, we've done a lot of trials in the past to find the optimum dressings. A lot of PhDs spent doing this. And what we've come up with is an algorithm which has been in use for several years now. This is the algorithm which we use, where we're mainly using silver dressings, but we do not use silver straight on the actual burn wound. There's always a layer of silicon, whether that be with Mepilex AG, which is the safe tack silicon barrier between the silver dressing and the wound, or Acticoat with a Mepitel interface, which again just prevents that direct contact of the silver dressing on the burn wound, because we know that silver is cytotoxic. So really what we're looking for is a balance between killing bugs and killing skin cells. And so you don't want too much silver unless your burn is already colonized, but you want enough silver to keep that colonization down so that your burn's got as much chance of rehabilitation early under that 17-day mark as possible. And so for different burns, which we see, we use different dressings, but this is the algorithm we use, and we're very happy to share with anyone. This is being used by a lot of the centres in Australia and around the world. And we've not really changed it over years because it seems to be very, very good. We also use a lot of negative pressure wound therapy. That seems to make a difference, but it only seems to make a difference if you're applying it early, certainly within the first 48 hours. But I personally think that really what you want is getting the negative pressure wound therapy on in the first few hours. If you can get on within the first 12 hours of burn, I think that's probably the best. What negative pressure wound therapy does to a burn wound, we really don't know, but certainly you reduce edema, increase vascularization, and the burn wounds certainly revitalize faster with negative pressure wound therapy. We've now done 4 randomized controlled trials looking at negative pressure wound therapy and burns, and there's absolutely no doubt in our mind that this works for kids. Now, this is one of the areas where kids are a bit different from adults. Little kids tolerate negative pressure wound therapy beautifully. It's almost like they haven't got any dressing on, but it really annoys adults. And so the tolerance to this, the burden behind the treatment is quite different as you go up in ages. But most of our burns are in the toddler age group, and so we have no problems with this. And with big burns, we're happy to cover as much as possible of the patient. We've gone up to 3/4 of the patient under negative pressure wound therapy for the big burns. But we've shown it significantly increases the rate of rehabilitation. So a lot of our patients have negative pressure, most of the kids who go to theatre for that initial scrub, and we're also using it as they come into emergency, putting it on awake if we can get the burn wound nice and clean. And we're leaving negative pressure on. If you put it on initially, we're leaving it on for a full week. Now, I'm going to show here 3 algorithms which we introduced. These algorithms were introduced about 3 years ago, and we've done slight modifications. Now, what I can say about algorithms is that you really have to create algorithms for your own center, your own population, and your own climate, because, as I say, we're a subtropical state in Australia, and some of the sort of conditions that the kids are going back to at home, because 92% of our patients are outpatients, they're not in the hospital, and they're going back to temperatures of 40 degrees centigrade, and a lot of the traditional dressings actually melt in the Queensland heat. So we create dressings for our own environment. What we don't want is dressings drying up, because that just increases itch, which is probably the #1 problem with burns today. So although I say this is what we use here, you've got to work out what's best for your own environment. But what we're emphasizing here in the algorithm is the importance of that first 24 hours. And for different sizes and depths of burns, we have different treatments. And so, again, I'm very happy to share this algorithm with everyone. There's no copyright in any of the things I'm showing here. So this is our first 24-hour algorithm. You can see we're taking a lot of kids to theatre. We're using a lot of negative pressure wound therapy. And, of course, for the big burns, which I must say, we're not the world experts in big burns, because we don't get that many. Of course, we get our own fair share, but the vast majority of the burns which we have here are small to medium-sized burns. And the vast majority are going to be partial thickness. So that's what we're experts in. You know, I refer to the Americans, Chinese, and the Indians to talk about big burns. But what we're experts on is what we see. So that's the first 24 hours. We also have an algorithm for between the first 24 hours and revitalization, and exactly what we do. And I won't go into this in detail. That I'm very happy to share this with everyone. But this is what we do here. And it just makes it very easy for our junior medical staff and senior medical staff, our nurses, allied health staff, so we're all on the same page. And then finally, we've got an algorithm for once the burn wound is revitalized and the ones who actually require scar management, and exactly what we do. So again, very happy to share all these. And this is what the change in practice has done for us. And what we're looking at is we moved into our new hospital in 2015, actually end of 2014. And so this is what's happened to the split thickness grafting rate for kids over these years. Now we treat, just to put you in the picture, about 1,200 kids with new burns a year here. So we're fairly busy, because in Australia, we have centralized units, one for each state for kids. So we kind of get most of the significant burns. So you can see that back in 2015, we were grafting almost 100 kids a year. Last year, we grafted 19. And that equates to about 1.5% of our burns population. So it's actually a small minority, 1.5%, that we're indium grafting. That all the rest are reepithelializing, usually within that first 17 days. In fact, we're sending less than 5% of our burns patients to our allied health staff for scar management. So more than 95% of our burns will reepithelize within 17 days, and we're actually discharging them just with advice. So that's what's happened by using these algorithms over the years. And this is a chart looking at the incidence of 4 different key features are in the pediatric burns world since 1999 till the end of last year. And you can see in the gray, you're looking at the inpatient rate. When I started here, all the burns patients were being admitted to the ward. And that was simply because we were doing daily dressings in baths. And so they had to be inpatients. Pain levels were high. They were there. Now it's between 7 and 8% of patients end up spending 24 hours in the ward. So it's a huge reduction of inpatient costs. And that is enormous savings for the health service. That's the most expensive thing you can do in Queensland, is admit a child to hospital. The optimum first aid really started at a very low rate when I got here. But after we did the studies and made this our mission to try and get as many patients as possible, the last time we measured it, it was above 70%. And I'm talking about optimal first aid, so that's full 20 minutes of cold running water. Now I think it's well above the 80s or even in the 90s for kids in Queensland and getting that optimum first aid. The kids getting grafting, you can see, has plummeted. It was 27% of all kids getting grafts when I started here. Now, as I say, it's down at 1.5%. So a huge reduction in grafting. And scar management started off at 33% of kids, which we saw, developed a scar. Now it's less than 5%. So how did we achieve this? Well, I've spoken about a lot of these things, but we introduced a lot of these principles gradually. So we started randomized control trials in 2000 for the BioBrand trial. Acticoat was introduced in 2001. Which was, the first dressing which we could leave on for several days. We did a lot of cytotoxicity studies way back in 2003. We determined what the optimal first aid was in 2007. And we used a lot of distraction in our unit, either with virtual reality, clown doctors for the really young patients, and we know that distraction works. It reduces pain and stress and anxiety, and increases the rate of reepithelialization. And so we're big in that front just now. The debridement evidence I was talking about before, we first showed that in 2008. The relationship between pain and reepithelialization, we finally got in 2011. What predicts the reepithelialization of a burn, we analyzed that and published that in a beautiful PhD in 2014. The negative pressure wound therapy, that all started about 8 years ago on acute burns. And our big RCTs on silver dressings and the dressing algorithm, we've now had that for 8 years. The QV lotion using that debridement was 5 years ago. And the escalated pain pathway for working out who needs more pain, we introduced that 4 years ago. And the debridement study under general anesthetic, that came out 4 years ago. And our big trials in negative pressure wound therapy, again, that was 4 years ago. And that first 24 hours algorithm came out in 2020. So we've been running that for a few years, and we've really not had to change it. That's really all I've got to say, but thank you very much for your attention, and happy to take any questions. Thank you very much.
Thank you very much, Prof. Kimball, and thank you to our global audience for watching through this real interesting journey of trajectory of burns management over the last few decades. It's really quite an honor to have such an expert view on how things have changed, both, you know, for you as a clinician, but also the different mechanisms by which we've got such a low skin grafting rate, by all accounts, in your unit. So congratulations on managing to get such a streamlined service and with such excellent results. So Dr. Glatt, we're very interested to hear your perspective on the basics of burn care.
Yes, thank you so much for inviting me to talk about this. And I'm really going to share my experience in a US burn center. And so we can contrast what our other speaker may talk about, but probably a lot of similarities and maybe some slight differences. So we just wanted to start with some burn care basics and just some US statistics. There's about 700,000 burns each year documented in the United States. There's probably many more that don't seek medical attention. And even of those, 95% are treated in an outpatient ambulatory setting. So really only 50 to 70,000 reach the hospital setting, 40,000 of which are treated in a designated burn center in the United States, of which we have 120 or so of those. About 30 to 40% of those are pediatric burn injuries. And sadly, we see about 12,000 deaths a year. In our country, really, the criteria listed here are those that, you know, we put out to, you know, to other hospitals to say, these are the types of patients we would like you to transfer for the patient's best interest to a burn center. So really anything over 5% full or 10% partial thickness injury should be in a designated center where people know how to resuscitate patients and to treat these injuries with, you know, multidisciplinary care. And certainly specialized areas of the body where scarring could be so devastating, like the face, hands, feet, genitalia, across joints. And then some of those other situations which can complicate a simple burn, such as an inhalational injury, something that's caused by electrical or chemicals, you know, sources. And then I do a lot of pediatric burns as well as our other speaker, and child abuse is another reason to kind of take the patient out of the home, even if it's a small burn, and protect them and figure out what's going on. And then many of our adult patients especially have comorbidities and pre-existing conditions, which, you know, may make a simple burn life-threatening. So they should be in a burn center. When we look at the mechanism of injury, again, we usually see scald burns and flame burns, and we can sometimes tell that a scald burn more likely is going to not be full thickness, whereas a flame burn, because of the temperatures, are often full thickness, and that helps guide us a little bit in our initial burn management. And then we see these other lesser frequent things such as contact burns, chemical, electrical, and those sorts of burns that can become, you know, deepen or change with time that we're not used to treating. Again, abuse and circumferential injuries have specialized issues as well. The reason we classify burn by depth, and it helps us to kind of get a sense if it's a scald, maybe we're looking at a superficial or deep partial versus a flame injury that may be more likely full thickness, or even what we used to call fourth degree, because it's very, very deep. And some of that helps us to determine how long we think it's going to heal. And as we talked about with scarring, and we'll talk about more, usually that 17 to 21 day time frame helps us to guide the patient on whether or not we think they're going to have scarring or not. And if they are, then, you know, that leads to a lot more care for the patient outside of the hospital to minimize and manage scarring. So that's a big deal. And then usually it helps us to also advise the patient or the family whether we think they're going to need surgery or not. You know, superficial injuries typically don't. And we'll go over different dressings and skin substitutes, which may help us to heal those. And then we also have those deeper injuries, which sometimes a deep partial goes to the OR for a skin graft, sometimes it doesn't, but a full thickness injury almost always does. And so that really, again, tells us about hospital stay, types of products we might need, scarring, aftercare, all of those things. So this is really our general principles of managing a burn. We like algorithms. It helps us to kind of be consistent with what we're doing for patients. And so certainly early on, we're looking at debriding that wound, whether that's surgical, mechanical, enzymatic. Those are ways of cleaning off the dead tissue. Helps us to look at that burn wound bed more carefully and determine what we think may be the depth of that injury. And even in the most experienced hands, we're not always right about the depth, but that's why we watch this and see them early on a daily basis. So our real combination of local wound care, soap and water, and then mechanical debridement of any devitalized tissue. And then that leads us into the next sort of arm of the algorithm, which is what do we put on this burn? We almost always use an antimicrobial, and it's almost always topical, but that can come in the form of topical antibiotics, or it can come in the form of silver dressings, and we're going to discuss some of that. And ultimately, we want that patient to reepithelialize or heal on their own with their own tissue, whether that's with a little assistance from us with, wound care or skin substitutes, or just letting them heal on their own. And one of our main stalwart, principles is we really want to minimize the pain. We see a lot of post-traumatic stress from patients who don't have good pain management, who are really traumatized by these injuries, and more so the care for these injuries than the injury itself. And so if we can deal with minimizing pain, it's such a big advantage to the patient. So this is just a list of some of the topical antimicrobials that we use almost on a daily basis. The big ones for us are really, a Zeroflow, which is a more porous type of, petrolatum type based dressing, in combination with topical antibiotic ointments like bacitracin, for example. And we also use a lot of collagenase, which is an ointment which has enzymatic activity, and the combination can work very nicely to clean up the wound very quickly. Some of these dressings we use in a more or these topicals, I should say, we use more in a specific type of situation, like sulfamyline, what we might use on ears and noses, cartilage, those sort of things. Silvadene, we don't use a whole lot of, but it's probably the most commonly used thing in the world at this point. And then the things we really consider when we're trying to make our decision tree as to what to do for the patient is how morbid is the wound itself, and then the morbidity of any sort of operative or non-operative management, optimizing function. So, again, if you have a growing child, it's one thing. If you don't have growth to expect, that's a different thing. But what kind of tissue is missing? What kind of closure options do we have? And then really, what kind of complications or problems will we cause with the closure? Because donor sites can be problematic. We look at the age of the patient, and we look at, patient and family desires as well. And then we look at, how big is the surface area of the wound? Where on the body is it? As a plastic surgeon, we're very interested in aesthetics and scarring, of course. And the key really is that sort of 17-day marker where we want to get that wound closed within that time to avoid the scar issue. And lastly, you see in all capitals is pain. If we can do things that don't have to be done daily, or the patient can be out of the hospital and the pain is minimized, it's a big win for us. So when we look at things on a depth level, and that's how I really work my algorithm, let's start with superficial partial. And again, you can see all of the issues related to pain management. Pain is important. It requires anesthesia to manage that if the patient is going to have a daily type of dressing change. And that amount of pain, we talked about having an effect on healing, but also on the length of stay. And it's surprising to know that the worse the pain is managed, again, we can have slower healing. And so that's really fascinating. And there's studies that we'll discuss. And then we look at quality of life issues, and as I alluded to earlier, PTSD. So a lot of these patients need psychological and other management after. So what is really the ideal dressing for superficial partial? Because most of these burns will heal with with any type of management. But again, you saw the focus for us is pain and expediting closure. And so what you see here is, you know, an image on the right of SafeTac technology, which is a silicone-based foam dressing in this case, as seen here. And you can see how lifting up the dressing with purple really doesn't disrupt the skin and the epithelium at all, whereas more adhesive type dressings are pulling up the epithelium and thereby causing some pain, but also delaying the healing. But for us, really the most ideal dressing maintains a moist environment. We talked about non-adherent and easy application and removal, and really that painless application and removal, so critical. Clearly, cost comes into play in any sort of management of any patient, but we'd like something cost-effective. We'd like something that at least protects us or minimizes the risk of infection, and clearly something that can stay on for several days up to a week means the patient doesn't always have to stay in the hospital, and that's a huge bonus. And that leads to less dressing changes. So here's some wounds, and we're talking again about a silver impregnated foam dressing as our main go-to for this type of wound. Unless anatomically, like the face, you can't really use this type of dressing, we can talk about that. But here's some examples of debriding the wound, applying our silver impregnated foam. It can be really applied almost anywhere. I don't have a follow-up there, but you can see how easy the application is, and you can expect this to also be easy to remove. Here's a child, but again, this can certainly extrapolate to a patient of any size, but here's a skull burn to the chest. And after a couple of days of enzymatic debridement, this was moist and pink, and we decided to use silver impregnated foam. And you can see it can be cut to size and cut to fit various different anatomies. And the patient went home, and a week later in the clinic, it was removed. And here he is 2 weeks later. There was no pain, no stress. Patient's not moving, crying, screaming, so not traumatized. And here's a 4-week and a 6-month, post-op visit. So still some pigmentary issues, but no scarring and no issues with pain management and or traumatic issues for the patient. Here's another patient, and you can see here, it's another child, but see how the dressing can be easily lifted up, and you can look at that wound bed. And what's interesting is you can see how the exudate perfectly matches the shape of that wound. So it's not spreading out to the side, causing maceration and other complications for the intact skin. And this dressing could potentially be laid back down and left in place longer, but in this case, it was changed. But here again, a happy, not crying child who wasn't traumatized by this dressing removal. And here he is at 4 weeks and 2 months. So see the area on the shoulder, took a little longer to heal. We have a little bit of scarring, which was dealt with scar management, but no need for surgery, skin grafting, creating donor sites, and other complications. And again, at 4 months, quite happy, and 6 months. This really went very much in line with the findings of a study that I was one of the participants in. And you can see the authors listed here. This was a study that compared the silver foam dressing with silver sulfadiazine cream. It was done about 12 years ago and was published in the burn journal, the JCBR. And you can see the title there, but the design methodology was a randomized controlled trial. We looked at partial thickness injuries that were less than 36 hours in time duration with a small to medium TBSA, 100 patients, randomized to either Mepilex AG or the silver foam or the silver sulfadiazine. And the treatment duration lasted up to 21 days. And what we looked at was hospital length of stay, how long to heal, the pain scores, in-use characteristics. So was it easy to put on, easy to take off, etc. The total cost, and the results are really shown here. So what you see here is the main results showed a 5.6 versus an 8.3 day compared to control with the Mepilex AG as far as the length of stay. And you see that indicated there with a significant p-value. There was no real significance in healing times as far as statistically, but you can see there was about a 4-day difference in that. And that 35% of the Mepilex patients were healed after 1 week, which was great. So they only had to really have one dressing change compared to only 20% of the Silvadene group. Again, when we looked at pain, I think that's really where the take-home message is here, is that we had significantly better pain management with the Mepilex AG in all different time frames within the study. So during application, while being worn, and while being removed. On removal, again, it's not statistically significant, but it's trending in that direction. As far as the ease of use and flexibility, you see dramatic differences, and the number of changes of dressing averaged only 2 per Mepilex patient, whereas 12 for the control group. When we look at cost of care, that was really another important factor. It was a savings of over $200 per patient in these healthcare costs in the study, very significant. And really what we looked at was less analgesics, and the cost of the dressing was really the bigger cost compared to the labor-intensive nature of having a daily dressing change. And again, you can see that here on this slide as well. So our conclusions were this was cost-effective compared to what the standard was. It helped with healing. It was safe, had minimal pain, cost, and ease of application. Another study here, that Dr. Kimball and others were the authors on, which talked about 3 different burn dressings for partial thickness injuries in children in a head-to-head comparison published in 2015. And this was another fascinating study, which talked about in a randomized control fashion, looking at less than 72-hour-old burns, under 10%, and randomized to receive either Acticoat, which is a silver nanocrystalline type of dressing, but it's not a foam, and it doesn't have the silicone technology. And then we looked at a Mepitel combined with the Acticoat. So the Mepitel has the safe tack, but it doesn't have the silver, so that was combined with the Acticoat. And then we looked at the Mepilex AG silver foam dressing, which we looked at in the previous study alone. And the treatment duration here was up to 14 days. And what we looked at was, what they looked at, I should say, is time to healing, different pain analysis, in-use characteristics. So what we looked at as far as results are here listed in this chart. And you can see the sort of median days to reepithelialization approached about 10 in the Acticoat or the Acticoat Mepitel group, whereas the Mepilex patients healed about 3 days faster. And that had significant p-values, even when comparing the Acticoat to the Mepilex, or the Acticoat with Mepitel with the Mepilex. Both of those head-to-head comparisons were statistically better on the Mepilex AG side. When we look at dressing removal and dressing application, at the time of the first dressing, we again found that the Mepilex AG was faster. It had less, difficulty and pain associated with it. And there was more difficulty in the patients that didn't have the safe tack technology. So the conclusions were that it showed advantages when using a silicone interface, dressings that adhere to the burn wound, as we showed in an earlier picture where the cells were being pulled off more traumatically in other types of dressings. That pain and that stripping of the cells is eliminated with the safe tack silicone technology, and that sort of minimizes the delays in wound healing. And the differences in epithelialization between Mepilex AG and the Acticoat plus Mepitel, so those are both, silicone products. So sort of the stripping doesn't explain it. And what we might be looking at here is this nanocrystalline silver product has a significantly higher amount of silver delivered to the wound, and perhaps there might be some cytotoxicity or excess release of silver from the dressings into the wound. So that remains to be delineated, but that's the hypothesis. So again, conclusions, Mepilex AG is an effective silver-containing dressing regarding healing times, pain, ease of use in children and also in adults. And using something with a silicone interface really can minimize that pain and that trauma, both physically and mentally, to the patient. So here now we have our deep partial thickness and our full thickness algorithm. And really we break that down at whether or not there's dermis left behind, or if there is not enough dermis left behind to, give you proper, quality tissue delivered in a simple skin graft. So if there is sufficient dermis, then we may do an autograft. In some cases, we may do a biologically active skin substitute, which may stimulate reepithelialization if there is that potential. But if there really just isn't any viable dermis at all left, then we're looking at providing dermis to that wound so that we can get, better quality skin, more supple. The dermis really provides that quality of life to the patient. And so that's our two-pronged approach. When we look at split thickness skin grafting for deeper burns, again, we focus on pain and we focus on donor site morbidity. We have multiple options in our pediatric patients. In adults, we don't think about the scalp as often, but the scalp is a wonderful donor site in any age group. Once the hair grows back, and it always grows back without really any issues of hair loss, then we have a hidden donor site. So that's really nice for the patients. In the thigh is the most common area, but a lot of times, especially in a young child, that's kind of the diaper area, and we can have morbidity from, sort of cleanliness in that area. And then it's easier to manage pain in the scalp where it's not moving, but we have different options for management of pain. But we certainly can have morbidity and prolongation of hospitalization from a donor site. So, pain management type dressings make a big difference. Here's some examples of a thigh donor site. And in this case, this was part of a study we were also involved in, really evaluating something called Mepilex Transfer AG. It's another Mepilex foam silicone-based dressing. And you can see here, here's a skin graft that has been applied. So first we have what's called Mepitel AG, which is, again, a safe tech technology, but a silver impregnated version of Mepitel. So we provide not only the antimicrobial, but we provide silver in reasonable doses. So this may be the solution to that 2015 arm of the study that had to add the Acticoat to the Mepitel. Now we have a Mepitel with silver in it. Here's the Mepilex Transfer AG on the donor area. And you can see a standard dressing. Here we are about a week out. And you can see how nicely and clean and dry these grafts are, and how well taken they are later on in the care of the patient. Nice healing there. Here's the donor area, and you can see at a week was really almost completely healed with some small areas that are still open, and the dressing can be reapplied. Again, for our scalp donor versus the thigh, again, similar dressing management, again, part of that study. Here we are, we shaved the head, and we were able to harvest quite a bit of skin from the scalp. And for those of you who don't remember, the scalp is disproportionately large in a small child than compared to an adult. So you can get quite a large surface area from the scalp. Here's the Mepilex Transfer AG that's been nicely conformed using staples and some, cutting and a little bit of, tailoring done here. And here's the skin graft applied to that foot. And here's the silver Mepitel dressing. And again, just a week later, these things are looking really great. And you can see, again, 3 months later, how the hair grows back beautifully. So again, to re-emphasize the scalp donor site benefits is listed here. The hair grows back. It really does have decreased pain because there's not a lot of movement and irritation from the diaper. Easy wound management and less visible scar. So to conclude, really, for our part here is that the use of dressings with silicone interfaces really should strongly be considered for use in any population, but especially children, mostly to reduce that need for painful dressing changes and the trauma associated with it. Being selective and careful with your donor sites. Again, we always poo-poo the donor site, but it really can have some morbidity to it and may increase pain and length of stay. So our bottom line is we want to treat the underlying cause, treat the pain, provide good undisturbed wound healing, and when we need to, think outside the box to help control those pain issues, because pain can be so devastating to the patient in many ways. Thank you.
We'll come to our global audience. If there are any questions, please use the interactive chat, and we'll be able to ask our experts anything that you would like answered. Dr. Glatt, can I come to you for your thoughts in terms of algorithms? I mean, I think that's such a wonderful way of standardizing the care for the whole member of the multidisciplinary burns team.
Absolutely. Yes. Thank you, Dr. Kimball, for that wonderful presentation. Absolutely. I learned a lot. And I am also a pediatric burn specialist myself. I don't do many adults either. So we felt that algorithms were very useful. We don't quite have the system that they might have in Queensland, because we have patients coming from different states with different socioeconomic, which everybody has. But for example, for us to get a patient in negative pressure, which I've always thought was a wonderful idea, within 4 hours or even 24 hours is virtually impossible for us in our system. It's a shame, but I've always read the papers on that topic and thought, well, we need to get it done quickly and then it would work. And we just were never able to get to that point. But maybe we should revisit that, and perseverance certainly would be like the way to go there. The grafting rates, I'm a firm believer in, aggressive first aid, soap and water, cooling, the same, even enzymatic debridement maybe helps with some of the deeper partial thickness burns as an early intervention. But I think what you're doing is great. We do a lot of distraction and PTSD, post-traumatic stress, we're looking at, painful dressing changes versus sedated dressing changes. And again, we're very aggressive at we don't have the same access to theater as they do in Dr. Kimball's unit, but we do sedated dressing changes in our unit within the first 12 to 24 hours, basically under anesthesia, but not in the operating room. But again, limiting that stress and hopefully getting those patients mentally to help give them the best effort at reepithelializing without deepening or without surgery.
What in the history should our global viewers be kind of cognizant of in terms of assessing that, doing that initial assessment of a wound that's, burns injury? You refer to the SafeTac technology, and, from your personal experience over the last 2 decades, how have you found that sort of, you remember obviously the earlier dressings that we used to use burns, and how adherent they were despite obviously best efforts for it to be a painless dressing. But how would you feel about, how do you feel that that's changed in terms of just through dressings that you would have used maybe a couple of decades ago to what you're using?
Yeah, I mean, it's really night and day. I mean, it's eliminated our need for changing dressings on a daily basis in a large percentage of our patients. And really, the Mepilex AG was the first in its class to come out, and it's really still our go-to dressing. It's been such a mainstay, especially in the pediatric burns, as far as we can put it on. They don't have to ever touch it. They come in a week later. Usually it's healed. If not, we reapply it. And this is not what we were, we used to have children screaming and kicking and crying in the burn unit, in the burn clinic for dressing changes that, now we don't have to do that anymore. And so it's really made such a difference.
It was sad times in those days, because it was it was traumatic, because every time they attended the clinic it was associated with, this is a painful thing that's going to happen. And now you see Mepitol just comes right off. There's no flinching or anything like that. So thank you very much for your insight. And we've got some interactive patient cases to discuss.
Sure.
So
of course, we're, the first thing we need to understand is the mechanism of injury and the size of the burn injury. We also have a high proportion of scald injuries over full thickness type of injuries. And so when we hear about flame injuries, we might think deeper burn. And when we hear about scald, we're more prone to think that we can get this to heal non-surgically with some of the things that we just discussed. The TBSA, as in Dr. Kimball's algorithm, dictates which direction we may go, whether the patient can go home in that first day with a 3% or smaller burn, for example, with a silver foam dressing, or if they need to be present in the unit with negative pressure, or with, we still do daily dressing changes on some patients. So whether they need to stay in the hospital, and then whether it's on the face or the hands where scarring is so critical versus another part of the body. Not that we discount scarring on the back or somewhere, but these other areas are so much more critical that we may do different interventions in those areas.
Thank you very much. And Prof. Kimball, can I come to you just to get clarification for our global audience? In terms of obviously the location and size of the burn, what's your sort of tried and tested method for assessing that TBSA, so the total body surface area of the burn?
Yes, very, very important. For kids, most of the burns we're seeing are small to medium size, so they're not difficult to measure. The mistake that a lot of people make is that they count erythema within the total body surface area, which you should not do. Which makes it slightly difficult, because if you take a picture of a burn, we do a lot of photographs, so all the referring centers send us pictures, so we know exactly what they're talking about. But if you take a picture very early, especially with scald injuries, you may see erythema, which then will blister and become much more apparent the real thickness of that burn after a few hours. So you got the time that picture has been taken is very, very important. But we generally speaking talking about the hand size of a child. So not your own hand, the child's hand, including fingers, is about 1% of body surface area. So that's a sort of rough guide. Of course, you can't use the rule of nines for kids because their heads are bigger, their lower limbs are relatively smaller. We actually use a nice app, and there's lots of apps in the world where you electronically shade in a picture of a child and it'll spit out the body surface area. We use actually the New South Wales Institute of Trauma app, which I think most Australians will use. And that's a very, very quick way of determining body surface area for the bigger burns. The smaller ones, the child hand is absolutely fine. But I emphasize this importance of burns deepening over the first 3 days. And so we tend not to talk about all the intricate different depths, whether it be superficial partial thickness, mid-dermal, deep dermal partial thickness, because that will all change. And so you cannot be certain about the thickness of a burn wound just by looking at it in that first day. So what we talk about is partial thickness burns and full thickness burns. And like I said in my presentation, full thickness burns are actually quite rare in our findings. A lot of burns which used to be thought were full thickness are actually deep dermal, because derm is to preserve there, even with the big burns which we see. So that's very important. And of course, we now know which kids have that escalated pain pathway, and we talked about that within the thing. So we know exactly what to do with most of our burns patients.
Thank you very much. And can I ask both of you gentlemen about obviously the fluid resuscitation? I think obviously in your algorithm, perhaps you'd be kind enough to share it again with us. Talk a little bit about sort of fluid resuscitation types of protocols that you both obviously advocate in your clinical practice.
Yeah, I mean, I'll just start. Yeah, again, we have to resuscitate the minority of our patients. So we tend to go along with the ANSBA guidelines. That's Australian New Zealand Burn Association guidelines. And guidelines change a little bit depending on what part of the world. So we fluid resuscitate kids if they're under 18 months, with anything greater than 10% body surface area burns. For the older than 18 months, it was up to 15%. And we use the Parkland formula. For the usual partial thickness burns, we use a multiplier of 2 within the Parkland formula. And we're resuscitating ideally with a substance like Hartmann's solution. And in kids, we tend to give maintenance fluids on top of the Parkland formula. But of course, these formulas are only a guide that all patients receiving fluid resuscitation will have a urinary catheter. And so we really go on urine output, because I think, over resuscitation of kids with larger burns is a big problem. And I think over resuscitation is actually worse than under resuscitation. We have not had a child in renal failure in the last couple of decades within our unit. And that's, of course, the danger of under resuscitation. So I'd much rather keeping the kids in the drier side rather than soaking them, because if you actually operate on kids that have been over resuscitated, there's this huge layer of jelly just underneath the skin where all the vessels are stretched, and I think that really deepens a burn. So you can't just write a formula up and go to bed. You've actually got to monitor that urine output every hour and adjust accordingly. For the larger burns, so we're talking about burns greater than sort of 20-25%, we're actually using a lot of albumin. So in the first 6 hours, we don't use albumin because it just leaks out the tissues and causes more problems. But after the first 6 hours, we're actually using albumin, and Hartmann's, it's 50-50 for the resuscitation. And if they're still requiring fluid resuscitation after that first 24 hours, which in our unit is actually quite rare, we're using 100% albumin, that 4%.
And thank you very much, Prof. And what about you, Dr. Glatt? What's your experience in your unit? What's your preference?
It's honestly very similar. Again, most of our patients are under 10% body surface area, so they tend not to get aggressive resuscitation or even catheters. But once we get into that 10-15% range, we also use the Parkland formula. The only thing, if there's a question of inhalation injury, you tend to need a little more fluid. So that's one thing, but definitely monitoring urine output is the key. And then we usually use ringers, but we may add dextrose in the smaller children in our maintenance, just so that because of their liver supplies and liver stores are depleted very rapidly. But otherwise, very similar. I agree that zone of stasis, if you kind of fill it with, interstitial fluid from over resuscitation, you're just dooming that tissue to convert to full thickness. So we tend to be a little under resuscitating as well.
Thanks, Dr. Glatt. Prof. Kimball, would you be kind enough to share that algorithm, the one that came before your split thickness skin grafting slide? Because I'd really like to get your thoughts as well, Dr. Glatt, about that, to see how you manage in terms of trying to optimize that burns wound in the long term. Obviously, to try and get minimal scarring whereby possible.
So you wanted the first 24 hours algorithm?
I think it's the one that came before the split thickness skin grafting slide. It was newer.
That's the first 24 hours algorithm. Sorry, I'm not hearing.
Thank you. I thought that was a really, really useful algorithm, and I think our audience will really find that one helpful. And for the audience, we'll include some of the algorithms and all the information that we've discussed and we'll discuss in this 60 minutes in our virtual booth, which will be under the handout section. So you'll see that on the right there on your screens. And as usual, any questions, please type that in the chat, and we'll ask our experts their opinions on any queries.
So that's the first 24 hours algorithm. So this is the first 24 hours algorithm, which really looks at the size of the burn, where it is, whether or not it's a clean burn.
Yes.
And, as I say, this works very well for us, but we've had to fight to get this algorithm working because, prior to introducing this, it was difficult to get these kids into theatre. We had to actually really put evidence behind it and publish this before we got people convinced. Now it's no problems. It's just routine practice that we're taking.
Yeah.
You know, at least 1 or 2 kids every single day with new burns to theatre for that initial debridement.
And all that research that you know, we've discussed has culminated in such a nice, concise algorithm there. I mean, let's talk through sort of major burns, the little steps that you have there. So you've said there at the top, you debride thoroughly as we've discussed with QV, and then you do the wash chlorhexidine rinse, and then you opt for Mepitel and the Acticoat dressing on there, and then
well, it really depends. You know, that we in our randomized controlled trial, just looking at burn wounds and the dressings, we actually showed that Miplex AG was a superior dressing to Acticoat and Mepitel. The reasons for that is probably because it contains less silver, and so it's less cytotoxic. They both have got the same SafeTac technology at that skin interface, so that when you remove the dressing, you don't remove new skin cells.
Yeah.
The only problem is that Miplex AG can't go under negative pressure wound therapy, and also, you know, the other factor is that Miplex AG, although it's a superb dressing in Queensland, you've got to change it twice a week because the wounds tend to get a bit dry, and so they get very, very itchy if it's left any more than 3 or 4 days. And so we vary the dressings accordingly to that. But because we're using a lot of negative pressure wound therapy, we're using a lot of Acticoat and Mepitel. You know, with major burns, we're using a lot of dermal templates now. We've got BTM, which we've been using for several years now because it started off in Australia. It's an Adelaide invention. So we use a lot of BTM as a dermal template, especially on our deep and large burns. And we're actually using dermal templates on the deep dermal partial thickness burns because it will actually take on that. It's a substance which seems to be very resistant to infection and will tolerate colonization very, very well. So things have changed, you know, quite a bit over the years with these new substances coming in, but you know, the basics are all there. Proper analgesia, getting that burn wound scrubbed down as fast as possible, getting that optimum dressing on, and really realistically, if you get things right in that 24 hours, everything else just follows. And as I say, more than 95% of our burns do not walk away with a scar.
That's really astounding, yes. And Dr. Glatt, how about yourselves when you're managing patients at this kind of, with this algorithm? Obviously, I know that you're not using this exact same algorithm, but would you say in terms of dressing?
Very similar. You know, I think the goal is to debride off the full thickness or dead tissue as quickly as possible to minimize inflammatory response and to minimize infection risks. We also use a lot of SafeTac technology. We've actually sort of improvised, and we've used the Miplex AG as our negative pressure sponge. So that's something you might consider. It kind of gives you both advantages. We also use a lot of templates and skin substitutes. If they're deeper partial thickness, we may use something more biologically active, maybe to stimulate that healing within 17 days without a graft. If they're full thickness, obviously, we've always used a lot of Integra, but we've recently adopted some of the Kerecis products and the BTM, and we're trying to see what the most optimal is. But again, replacing that dermis, again, futuristically minimizes contracture, we think, in growing children, and that's the idea there.
That's fantastic. Actually, in a month's time, our next Global Innovation in Wound Care Summit series is actually on skin substitutes, and we have actually got BTM and the fish skin technology from Kerecis, amongst other technologies, and they're all going to be discussed with interactive patient cases. So we're really excited about that.
You'll have to invite us to that one. Yeah.
Oh, we will. Yeah, for sure. Can I just finish by asking you, gentlemen, in terms of the future of burns technology, in terms of the future of burns management, how do each of you envisage progress to be made in terms of essentially trying to get to minimizing scarring ultimately? Is our, I guess, as a clinician, that's our goal. Can I come to you first, Prof. Kimball?
Yeah, it's all, this, it's a term we use now, towards zero, that really what we're staring down the barrel of is no patients requiring a skin graft and no patients ending up with the scar. That's the ultimate goal. We're getting very, very close to that. Inevitably, you're going to have some kids who have got large, deep burns, but instead of skin grafting them in the future, I'm sure we'll be getting dermal templates and seeding them with the patient's own cells. So in that initial scrub, you take a biopsy, you're growing cells up, fibroblasts and keratinocytes, implanting them on a dermal template. And then, if you can speed that whole process up, you've actually got composite skin grafts to use on that patient within a couple of weeks. And what you're going to be doing is temporizing that burn until that time with something like a dermal template and pressure wound therapy. So that's what I see in the future, is zero grafts, and this getting as close to zero with scarring as possible. And the kids who do develop scars, I don't think we'll be reconstructing them in the future, because our scar management techniques are so good with the use of silicons, microneedling, all the different lasers we've got. So I think the outlook for burns, even major burns in kids, is looking very, very rosy.
That's such a really optimistic future, yeah. And Dr. Glatt, how about yourself? What's your
Again, yeah, it's exciting times with all of the new technologies that are being applied to wounds and burns with skin substitutes. I think ultimately, if we don't get a skin graft out of a box, which I think is the other holy grail, where you don't even have to harvest any of the patient's own cells, the RECELL technology has changed things quite a bit as far as minimizing donor sites and the scarring associated with that. Another Australian invention. And then, yeah, definitely I've thought about seeding my dermal templates with cells now already, and I haven't done it yet, but it's certainly something I would consider doing, because people have done that with hair follicles and other ways of bringing cells into grafts with some success. So I think whether it's a biopsy and done, brought to the patient, later on, or if it's a bedside idea with RECELL and other technologies merged together in a composite, I do agree with that. And certainly our scar management techniques have improved as well. So I'm in full agreement.
It's really incredible when you look back to 20 years ago with sort of Fiona Wood and kind of the research that was coming out of Australia and sort of cultured keratinocytes. And now we're actually essentially making that a reality in the next couple of years, where that's going to be part and parcel of every burns management potentially that would have previously required weeks and months of ongoing treatments. So thanks again for joining us for this episode of the Wound Care Global Innovation and Wound Care Summit series. It's been a real pleasure to spend the last 60 minutes with you both. And we're really grateful to you answering questions from the audience as well. And don't forget, this is available on demand on Spotify, SoundCloud, Apple Podcasts, YouTube, and our website, as well as on the Molnica Hub. So thanks again once and all, and we'll hope to see you in the next event.
Thank you, everyone. It's been great.
Thank you.